Hello, welcome and thank you for attending our inaugural Alumni Voices event. I am Dr. Jack Folby, president of the Medical Alumni Association, and forgive me if I turn this way occasionally because I do have some notes on another screen and I just want to make sure that that I cover certain things. I'm a proud member of a class of 1989, and I'll be co-moderating with Dr. Ina Sala. She's a member of the Medical Alumni Association Board of Governors and a proud 2019 graduate. Wayne State University School of Medicine has over 24,000 living alumni across the globe, many of whom, like our distinguished panelists tonight, are highly engaged and sought after experts in their fields. I'm amazed when I go to the reunion weekends during our CME portion and we hear these incredible speakers, and they are typically alumni from Wayne State School of Medicine. The Medical Alumni Association developed and sponsored Alumni Voices as a way to address and dissect interesting and relevant topics while utilizing the expertise of our graduates. And honestly, who can think of a more timely and relevant topic than the intersectionality of politics and medicine? Ina, will you introduce our panelists?
I would. Thank you, Dr. Folb. So I'm absolutely thrilled to have the honor to be able to introduce all of our panelists today. And I'd like to start with a disclaimer that these bios are very abbreviated versions of their full bios. So, you know, they've all had very exceptional careers, long careers in, medicine and obviously politics recently for some of them. However, all of their full bios are on the alumni website, so feel free to log in and be able to access their full bios there. So with that said, I'll start with Dr. LaQuandra Nesbitt, who's class of 2003. She's a board-certified family physician with over a decade of experience leading the population health initiatives and governmental public health agencies. Dr. Nesbitt currently serves as the Director of District of Columbia with Department of Health in Washington, D.C. This is a position that she's held since 2015 when she was appointed there by Mayor Muriel Bowser. Prior to her role in D.C., Dr. Nesbitt has served as the Director of Louisville Metro Department of Public Health and Wellness. Well, obviously there she led many initiatives that were focused on the Affordable Care Act implementation as well as violence prevention. So Dr. Nesbitt, thank you so much for your time today. Is there anything else you'd like to add? You're all good? So I'll move over to the next panelist, Dr. Joe Schwarz, who's class of 1964. He's currently a lecturer in public policy at the University of Michigan Ford School. He has been in private practice as an otolaryngologist in Battle Creek, Michigan for over 42 years. And Dr. Schwarz served in this Michigan State from 1993 all the way up to 2002, and subsequently as a member of Congress from 2005 all the way up to 2007. Currently, Dr. Schwarz is serving on the board of directors of Voters Non-Politicians, which is a statewide organization that has successfully pursued ballot initiatives to end gerrymandering in Michigan's congressional and legislative districts. Dr. Schwarz, thank you for your time today, and anything that you would like to add prior to moving on to Dr. Spencer.
Not at all. I'll think of something.
So last but not least, Dr. Craig Spencer, class of 2003. He's currently Director of Global Health and Emergency Medicine at New York-Presbyterian Columbia University Medical Center, which is right down the street from me. He divides his time between providing clinical care for patients in New York, as well as working internationally in public health and humanitarian responses. Dr. Spencer is a member of Board of Directors for Doctors Without Borders USA and is a frequent guest, which I'm sure all of you have seen on CNBC. Dr. Spencer, thank you for your time, and I know that you just had a baby, so I'm sure your hands are full, so certainly very much appreciate you being here with us today. Any special comments? I'm sure you'd much rather be home changing diapers at the moment.
Well, I have two kids. This is actually this is a nice retreat. And you said last but not least, but I just want to point out that I'm certainly not a politician, and I'm least amongst this crowd, but I'm very happy to be here and happy to contribute. Thanks for having me.
I'm happy. Yeah, we're happy to have you all. So thanks everyone for your time. I'm sure you've had busy days today, so very much appreciate you being here with us today. With that said, I'll move over to Jack and we'll get started.
Thank you so much, and thank you all for participating, and thank you to all of our guests who are on this Zoom call. So several guests submitted questions when they registered. So I'm going to start with those, and you know, some of them are going to seem kind of political or maybe a little odd, but these are questions, and these are questions that sometimes, you know, come from patients who actually, you know, have asked things like this. So, for example, the first one, and it's for all of you, what do you or would you say to patients who insist COVID-19 is a hoax and believe that the medical professionals make money with the COVID-19 diagnosis?
Who do you want to start?
Go ahead, Dr. Schwarz.
Dr. Schwarz, why don't you go ahead?
Tell them they're wrong. The science contradicts their beliefs. I try to convince them politely that they are wrong, and just do the very best I can, and get a scowl on my face. And if they read my lips, they probably see me saying "dumb idiot." But you can't do that. You can't get in people's face and argue with them. It gets you nothing. You do your very best to convince, and that's what I have done and continue to do, even though it's enervating sometimes to do so.
Yeah, I agree with Dr. Schwarz. One of the things that I've learned over the past decade or so is that it's difficult to be rational with irrational people. And folks who have been convinced that COVID-19 is a hoax and it's not real, despite it having claimed over 500,000 lives in this country, or nearly 500,000 lives in this country, I would categorize as being irrational people. And our conventional medical wisdom and science would make it very difficult for us to have science-based and clinical-based conversations with those individuals, but yet we try, and it can be a very frustrating experience and interaction with them. The other thing too is for people who believe that this is some kind of way financially lucrative for the clinician who is sitting directly across from them, the care provided to individuals, especially in the outpatient setting, or for COVID-19, is the lowest compensated or reimbursed care that you can likely provide in the outpatient setting. So doctors who are diagnosing people with COVID-19 by way of a test and giving them supportive therapy don't stand to make much money at all off of a COVID diagnosis. So I think people could be disabused of that notion in terms of the primary care provider or the infectious disease clinician or the emergency medicine doc who's given someone a diagnosis and they have to go home, which is how most people recover, somehow being enriched by these diagnoses.
I think that covers it well. The only thing that I would add, and what I've been trying to share, is that if we were using COVID as a way to make money, we chose probably the worst possible way to do so. It would be like buying Bitcoin when it's $50,000 and selling it when it's $20,000. You know, what people don't understand is that even for inpatient care, maybe COVID pneumonia itself is reimbursed at a little bit higher rate than regular pneumonia. But what I explain to people is that in the resuscitation of one COVID patient, it can take 5 to 7 providers like myself an hour to 2 hours, which from a financial perspective is really tough on an emergency department. And also when you look at it, the amount of care that we put in terms of the amount of reimbursement that we get back, for me, it doesn't make a difference. I'll make just as much money as a salaried employee, you know, taking care of 30 COVID patients in one day and losing 5 of them as I would working in an urgent care, taking care of, you know, of sprains and other issues. So from my perspective, it doesn't change much. For a lot of other people working in similar positions as myself, it doesn't change much for our reimbursement. Unfortunately, what I think it does is it further politicizes an issue and undermines the authority of public health professionals and physicians who need to be seen as trusted resources and trusted voices throughout this. And unfortunately, that has been undermined all too often.
Yeah, I can also add that, as an anesthesiologist, a lot of our resources were diverted also. So, the highly compensated outpatient surgery that we depend on was gone. And we were really manning the airway team. And that's very low reimbursement for just doing laryngoscopies, but it was so vital to what we were doing. So, yeah, it's amazing that thought's out there. And I agree with all the panelists that we just need to educate the patients and shout our feelings.
Yeah, and that's something I would add. Is there anything that we can do on top of talking to patients individually? Is there, as scientists, as physicians, to reach out to a larger population versus just the patients that we see?
I think one of the things that we note is even with the type of screening and diagnostic tools that are available, they've been subject to an inordinate amount of criticism by people who don't understand the practice of clinical medicine or the practice of public health. There are a number of diagnostic tests that people run to the urgent care to get that have low sensitivity and low specificity. Urinalysis, strep test, the annual flu test, flu diagnostic test that tells someone if they have influenza A and B, but yet people have the utmost confidence in those tests when they go to get them from their doctor's offices. And now we've become so myopically focused on how reliable every single COVID test is, one over the other, that, I get a number of letters from people who disclose in the first statement, I'm no doctor or public health expert, but I read in XYZ newspaper that the cycle times, they're using phrases that they can't even really truly comprehend based on their professional background and the news clips that they've reviewed. But they then want to call into question whether or not we are accurately diagnosing people or whether or not all of these individuals really have COVID-19. Whereas they would never do that if we said that, this is the number of people who had strep every year, or this is the number of people through our very small surveillance programs have influenza every year. People don't question that. So I agree, it's because this has been politicized so much. What the medical community can do is to help people get some perspective around how diagnostic tests are used, how clinical medicine is practiced, how public health really is practiced, and help to shift some of those perspectives so that they understand the true context in which these decisions are made to depoliticize how COVID-19 has been managed in this country over the past year or so.
Yeah, and to stay kind of in that COVID topic, one question that came through more specifically for Dr. Spencer, and obviously all of you guys can answer, but can you talk the national and international response to COVID and the politics around a global response?
Sure. Yeah. Much of the past year I have spent completely uncompensated, I should add, doing hundreds of interviews on cable news, writing a bunch of articles for the New York Times, the Atlantic, Washington Post, really trying to get exactly this information that Dr. Nesbitt is talking about out to the general public, out to people like my parents, who quite frankly, even to this day, have a lot of questions and don't necessarily believe everything that I've been trying to explain to the general public and them as well. But in terms of the domestic and the international response, I've been concerned for years that we wouldn't be adequately prepared for a pandemic in this country for a lot of reasons. One, we tore apart a lot of the architecture, that pandemic preparedness architecture that was put in place in 2014 and 2015 with our Ebola response in West Africa. There were things that were put in place at the level of the White House and the National Security Council to have a biopreparedness lead, and that was removed. A lot of the funding, a lot of support for public health itself has been diminished in the past 12, 13 years. And so I knew beforehand that we probably wouldn't respond well, or well enough as many expected. I did not think we would respond nearly as poorly as we did. And at points I felt like the administration was actively working against a lot of the people who were trying to end this pandemic. On a global scale, I have a lot of concerns in terms of the inequities that we see, domestically being amplified all across the world. I just wrote an article today that I personally have received more doses of a COVID vaccine than 130 countries. And this will persist for another 2 years. Places in sub-Saharan Africa where friends of mine work won't be vaccinated until 2023, even if their risk of getting COVID is as high as mine or higher. So there's a lot of concern, a lot of question that I have in terms of, you know, how we've responded, whether we'll learn our lessons and make the changes financially, structurally to make sure we respond better next time, and what we'll do, not just on a domestic, but on an international scale to prepare not just in the US, but the rest of the world. It's cliche, but everyone says we're not safe until we're all safe. And I think with COVID, that's 100% true.
Dr. Nesbitt, you know, you work in the Washington, D.C., you know, area, public arena. How do you feel it's going from providing vaccines to those in need and maybe those who have very, very difficult time getting access?
Sure. We have been intentionally focused on an equity framework in the District of Columbia for the past 6 years. I've been here for about 6 years. And some of that work predates me. I've been in DC off and on for the past 10 years or so. And part of that is because the population health approach that we take recognizes that you can't do population health management without looking through an equity lens, right? So we're not going to improve the health of our community or our country as a whole if we don't work to eliminate inequities in healthcare access and health outcomes. And so everything that we do in terms of how we allocate funding, how we allocate resources, how we distribute our healthcare facility resources, everything is done through an equity lens. So as we set out to implement our COVID-19 vaccination program, we were very intentional in terms of where our vaccination sites and clinics would be in the District of Columbia. Now, as we got out of our first group of people we were vaccinating, our healthcare workers, those in long-term care facilities, and into the first sort of general population area, those people 65 and older, even that decision was based on an equity framework. The CDC, which we follow very closely, I've had a close working relationship with the CDC for the majority of my career, recommended individuals 75 and older. Our life expectancy differences in the District of Columbia would have left our most impacted communities behind if we would have started at age 75 and older. So we started at age 65 and older because that gave us the opportunity to extend access to vaccination to our seniors, who were actually the seniors who were most disproportionately impacted by COVID. So our equity framework really starts with how we set our policy at a high level. So we haven't only focused on how do we make sure people can actually schedule appointments, but how the system and the policy decisions really enable that. Now, we did have to get in the weeds on the scheduling piece and allow for scheduling, advanced access to scheduling for communities and neighborhoods that have a disproportionate burden of disease. We've done that. That's been met with mixed reviews because most people like the concept of equity. But when it's actually practiced, some people don't think it's fair. So we've been experiencing some of that. But I don't think we should have this conversation without an appreciation for what vaccine hesitancy and the lack of confidence in vaccines and the trust issues that communities of color have with institutions such as the healthcare system, government overall, has to do with how those communities of color demand the vaccine even when the supply is there. So we can do all we can on the supply and the system in the first place, but if we don't help drive the demand by answering all of their questions, helping to build that trust by having a lot of credible messages in the community, they won't meet us where the supply has actually been created. So it's multiple prongs to our approach, but we're doing the best we can. And we'll continue to innovate in terms of making sure that we don't have gaps, wide gaps between communities of color and whites in terms of actually accessing the vaccine here in the district.
Dr. Schwarz, I have a question here. You're involved, well, you know, with the VA veterans and veterans getting access to health care. I'm not really familiar with what the response has been for the veterans and how well even veteran hospitals are doing as far as distributing the vaccine.
think it's pretty good. We have a large veterans hospital in Battle Creek, and they have had a clinic at the hospital itself, aimed at veterans from anywhere that wanted to come and be vaccinated there. So they're participating. I think they're doing what they can do, and I'm very supportive of what they're doing. But they did have it, and I am assuming, and it is only an assumption, that other veterans hospitals did precisely what our veterans hospital did here in Battle Creek.
So Ina, you're kind of keeping an eye on the chat window, I know. So I want to let everybody know who's a guest on this call. You can submit questions to our panel via the chat. And Ina, why don't you go ahead?
Yeah, and I just wanted to follow up with Dr. Nesbitt. There's a question that came through about really what are your plans to ensure that vaccination distribution to that vulnerable population that you just discussed, and how do we address that in spite of what's stated obviously by the media and the locations of where the wealthy white areas are obviously gaining a bit more out of this distribution than the most vulnerable population. So what do we do there? What are the plans to bridge that gap?
Yeah, and I think one of the benefits, there's benefits and drawbacks in terms of the media attention to the COVID-19 pandemic, and what the experiences of the communities in the U.S. are not homogenous, right? So we're very heterogeneous in terms of our approaches to doing things and how we problem solve. And so you hear this global discussion of white communities are getting an advantage over non-white communities. Some of the challenge that we have is really there's not good race and ethnicity data. So you look at that data and there's so much race and ethnicity data that is missing. In my data set, I'm probably missing ethnicity on 40 to 60% of our population. And so I'm left to use geography as a proxy for race and for ethnicity in particular. Race, I have a little bit better information on. So there are things that you can do outside of the system level things that I described, right? Making sure that the sites are located in the communities that have the highest burden of disease, which happen to be communities of color as it relates to COVID. Now we know that people with privilege and means will drive into those communities and access those sites, right? So there's other things that you have to do. Most states are using pre-registration, so you can create an advantage for registration for people in those communities, and we've done that. The other things that you can do is create partnerships with trusted community organizations. So we have a faith-based partnership that allows our places of worship that have done a really good job of being credible messengers in communities of color. We allow them to have vaccine allocated, that they do drives to help get people registered. And then we come on site with a healthcare provider that can manage the complex storage and handling requirements of vaccine on site using mobile resources, and we vaccinate people on the campus of places of worship in our community. We've also worked with our housing authority, our local housing authority, which is usually low income and subsidized housing, to be able to go on site into our densely populated housing communities, especially those that are age restricted, where the likelihood that individuals may have transportation or mobility barriers to getting out to vaccine clinics and offer vaccination on site to be able to do those things. But most importantly, I prioritize, I don't have a lot of extra time. And so in addition to the press conferences that I do a couple times a week, I've really prioritized accepting those types of sort of panels and town halls that focus on being able to do direct Q&A with the community and answering any questions that they have about the vaccine, making sure people understand the difference between having a reaction to the vaccine that is just ramping up your immune system versus what people consider to be adverse events or side effects, making sure people understand it doesn't change your DNA, right? So answering all of those types of questions. And I think people having actual access to a physician to answer those types of questions can help move them along. You can open up large mass vaccination sites, but all mass vaccination sites do is create access for people who are already ready to take the vaccine. You have to create demand for the vaccine in communities of color, and the best way to do that is through healthcare providers or other individuals they already have trust with. And if you don't do that part, you're just gonna widen the gap between who's access.
Craig, did you wanted to say something?
No, I think Dr. Nesbitt got it all perfectly. I was just thinking and reflecting back today on the announcement this morning from the administration, not only just working to increase the number of vaccine doses and targeting places like arenas and large vaccination events, but forging relationships with community health centers and meeting people at the places where they are, as opposed to asking them to come to these, big vaccination drives. And I think that's going to be key for everyone, for communities of color, but really even for everyone who, once we get to the end of March, early April, it may be that we've gotten through the majority of people who are able and, and are willing to be vaccinated. Then we're going to have to convince everybody else to come in and get a shot. So we need to meet people where they are. Opening up a vaccine drive in Madison Square Garden or wherever it may be is great. But as Dr. Nesbitt said, we'll see the exact same thing that we've seen here in New York City, which is people on the Upper West Side, the Upper East Side, the wealthiest areas of the city, were able to leave the city during COVID. Their levels of infection from COVID were just a fraction of people in the Bronx and in the Queens. When you look at who's been vaccinated, now we're finally getting this data. You look at who has been vaccinated in New York City, it's people in the Upper West Side, it's people in the Upper East Side, it's people that have access, it's people that know people who know people that know how to get an appointment or are able to use some of that fungible time that they have to wait online and get one of these appointments. And that needs to change.
Yeah, and kind of, Dr. Fulb, I'm sorry, but there's a question that just came through. How can we reestablish that relationship and respect for CDC and WHO and other related organizations? There obviously people still are kind of hesitant because of the mixed messages that they feel like they're getting from these organizations. So how do we kind of reestablish that relationship between these three organizations?
Organized medicine has always been very interesting in this regard. And I've stayed attached to organized medicine as a public health, I spend most of my time on public health now as opposed to clinical medicine. But what's been interesting in the past several weeks or past couple of months is as the CDC's Advisory Committee on Immunization Practices that has experts from a wide range, right? They have clinicians who practice, pediatrics, OB, internal medicine, family medicine, infectious disease physicians, and they have public health practitioners. They have folks who are in the space of nursing. I mean, it's a wide array of individuals who have expertise. All came together and made recommendations as to how we should move through this process. Managing pandemics and administering countermeasures, whether it be a vaccine or medications, is not a new concept to us. We actually plan for this. We have playbooks. We know that supply is going to be constrained anytime you're developing a new therapeutic that has to be manufactured and brought to scale. And so much of how the phased approach to vaccination is developed in assessing and looking at the epidemiology of the populations who are impacted. Those things were a copious review of the science and is open to a constant review of the science so that we can pivot when necessary to be able to vaccinate the groups at the highest risk. Nonetheless, we are petitioned, now we're talking about the politics of this, we are petitioned frequently by specialty groups and trade associations to deviate from the recommendations of the CDC and the World Health Organization. And then competition starts to get created around different trade associations or specialty groups. This group that's advocating for cancer patients, this group that's advocating for individuals with intellectual and developmental disabilities, this group that's advocating for women with high-risk pregnancies. So all of this competition happens where everybody should go first. Well, everybody can't go first, right? So there has to be some way that we agree to look at what the science tells us about the populations with the highest risk, and we develop a plan from going there, knowing that we will eventually have enough vaccine for everyone and we'll be able to move through our rubric. So what we have to agree to do as a society, as health professionals, some who practice public health, some who work collectively with public health. One of my driving five principles is to close the chasm between clinical medicine and public health, right? We enrich each other. We don't compete with each other in terms of managing the public's health globally, is to really be able to manage how we make these decisions and recognize that we have to do the greatest good for the greatest number of people when we're in a pandemic environment. And so to be able to rebuild the confidence in the CDC and the World Health Organization is to recognize that a lot of people in the clinical medicine and the public health space come together, review the science and the data, and make recommendations to the CDC. And they're doing it in a way that integrates both public health and clinical medicine, right? So we're looking at the individual's best interest as it relates to the public's best interest. And I think that's the way that we get back to that. But this notion that we can have all of the societies competing against one another is what dilutes the confidence in our core institutions that have had the respect of our country for a very long time. CDC historically had been the most trusted federal agency in our country. So I don't think it's going to take much for us to get back there, but we have to kind of stop this competition about who goes first and recognize that we'll eventually get to everyone and let the data drive our decision making.
Do you think that, I've heard from some family practitioners who, are involved with immunizations, every year. And they feel that they should be more empowered to, provide immunization for their patients. They feel that they can do a great job triaging who's in need first. Do you think that they've been left out, or do you think they're going to be part of the future?
So this is part of that closing the chasm between public health and clinical medicine. We've done a lot locally to educate people on this framework. When you look at the framework for vaccine supply and the phased rollout to vaccination, you have to start with a smaller network of providers initially because you don't have enough vaccine initially to have a large network. And you're trying to reach the most critically impacted populations to be able to reduce the strain on your health system, reduce the strain on your public health system, and to keep your society functioning. So the initial goal when you have a constrained supply is not to be able to vaccinate any member of the general public, right? So we're not in a position in this country where we can line all 300 million plus people up, assess their individual risk from a health perspective, and give everybody a ticket 1 through 300 million plus and say, you get vaccinated this way in this order, right? And then allow their individual physician to get a dose for them to vaccinate them. That's not how the process works. We have to think about collective risk based on a number of shared risk factors, based on a number of functions, and then group people in that way. And roll out the process based on the amount of vaccine that is available. Now, as the amount of vaccine gets wider, the network of providers who have access to vaccine gets wider, and the number of people who become eligible for vaccine gets wider as their risk for exposure to COVID, death and severe illness for COVID, and passing COVID on to people gets lower, right? So that's how that expansion occurs. So yes, these primary care providers will eventually be able to vaccinate individuals as vaccine supply increases and as our networks increase. As Dr. Spencer mentioned, we have some primary care providers who are part of our health center networks that serve some of our publicly insured or underinsured individuals in many communities. They're receiving vaccines. Some of them have been receiving vaccine from their states. Some of them will start receiving vaccine directly from the federal government. They're primary care providers. But individual primary care providers that are in private practice with patient volumes of 20 to 30 patients per day are not yet in the network, but they will be eventually as vaccine supply increases.
Dr. Schwarz?
I have no comment on this issue. What we're trying to do out here in rural Michigan is to get as many shots in as many arms as possible, and that's our goal. All the other information is very helpful, but yeah, our goals are pretty simple here. Get as many shots in as many arms as possible, and we continue to do that.
Dr. Schwarz, you just mentioned, you're in rural Michigan. Politics are a little bit different there, but you're a physician, and you've had positions on same-sex marriage, abortion rights, stem cell research that could have put you in the crosshairs of your party. How did you balance your decisions as an elected official in the Republican Party and with your education as a physician and your career as a physician?
My positions have never changed on those issues. I had problems with the party all along, 16 years in the state Senate, in my time in Congress, years in between my time as mayor of Battle Creek, city of 60,000 people. I think for the rank and file of the Republican Party, they would call me too liberal. I would call myself too sensible. That's what that's what I did, and that's how I stood. And in the end, that's how I lost my seat in Congress, because the far right came after me with hammer and tongs and took me out in a primary election, the old method of primarying someone out when only the core votes, the hard right votes, and that's what happened. But I never stepped down. I haven't stepped down. I won't step down. There's one thing to being a slightly right of center, conservatively somewhat, on economic issues, which is where I am. There's another thing of being sensible and considerate and realistic, modern, I might even use, on the issues that you mentioned. And that's where I have been, that's where I am, and that's where I'll continue to be. The Republican Party will continue to fall off to the right unless they correct themselves. And I suggest there's a couple of really good op-ed pieces in today's New York Times that address this issue and how far to the right the Republican Party, out here in the Midwest, elsewhere as well, has fallen. And I must say, if you take a look at the Michigan legislature now, if you take a look at the Congress, the House of Representatives, the seats that are Republican seats, an increasing number are held by people from the hard right, and the moderates, which I proudly call myself, the moderates aren't in pretty good shape anymore. And about 4 years ago, I essentially disassociated myself from the party and now identify as an independent.
And just to kind of change gears a little bit here, perhaps for Dr. Spencer, you've had obviously a very personal and public example of, collision of politics and medicine when Donald Trump vilified you over contracting Ebola. How did that experience, affect you personally and obviously professionally as well?
Yeah, that was in 2014 when I had been working in West Africa. I'm taking care of Ebola patients, and actually he wasn't on my radar at that time. And it wasn't until many years later that I realized he had called me selfish after taking care of Ebola patients. But it really came out after, his illness, his hospitalization, and, me being so frustrated seeing him put others at risk when he, went on a joyride with people inside of a hermetically sealed car, knowing that he was potentially infectious. And it was a small scale example of the large scale failure. And, I don't want to get in a tit for tat with the president or anyone else on public health policy or what we need to be doing. At least on that level, I want to have substantial discussion. But at that point, it was just too overwhelming, too frustrating, and something needed to be said. It's unfortunate, but I guess in a sense, I'm glad to know that we've disagreed on a lot of things for at least 7 years.
At the outset, you mentioned you kind of could predict some of these things because of your experience with Ebola and where you thought some of the focus was going or turned away from. You wrote something about lessons learned and lessons forgotten. We've spent trillions of dollars. We've learned a lot about vaccinations, and we're continuing to learn about how to, disperse it. What do you think are the key lessons we've learned, and what do you think we're going to forget?
Yeah, this wasn't surprising, right? I read an article in 2018 that we weren't prepared for a pandemic. I read an article in 2019 that we weren't prepared for a pandemic, that we'd forgotten the lessons already of Ebola. And Ebola really didn't dramatically impact the average American here in the US, even though at one point the majority of people thought someone in their household or in their friend group would get Ebola. We knew that that necessarily wasn't the case. There was a failure of communication at a political and at a media level as well. In 2015 in the New England Journal, I wrote a perspective piece where I said, we don't need 50 different viewpoints that change with the proximity to the next election. You know, trying to argue that the way Andrew Cuomo and Chris Christie had responded in New Jersey and in New York, you know, with their, they made it very clear that they were acting in even more strict observance and more of an abundance of caution than was necessitated by the public health guidance at that time. My argument was that we don't need 50 different viewpoints that change with the proximity to the next election. We need one salient and codified viewpoint coming from the public health authority in the US, which is the Centers for Disease Control. You know, I didn't realize that, you know, how dramatically worse things would be, you know, in 2020 and into 2021, when so much, as Dr. Nesbitt has pointed out, and the question had alluded to, you know, the FDA and the CDC, the long trusted institutions, which we've, you know, even though they've been, you know, political institutions, have not been politicized in the way that they had been in the past year. What do we need to do? I think that there's a lot that we need to do. One, we need to understand that American exceptionalism doesn't mean that we can be forgetful. We were rated as #1 in the Global Health Security Index in terms of pandemic preparedness. And we've had the most deaths by far of any country in the world because of our failure to respond and our failure to treat this appropriately. We need to not only finance pandemic preparedness, we need to focus on the issues that have made us so vulnerable. And a lot of that is issues of underlying inequity. The fact that we're the wealthiest country in the world and we spend the most on healthcare per capita, but we have some absolutely abysmal health outcomes, and they're so absolutely unequal. You know, where I live in New York City, on one train line, you know, people's life expectancy can be 10, 15 years different just depending on the zip code where they live. And so these things need to be addressed. And these are not just issues of access and equity at a baseline. These are, you know, predisposing factors that made us much more susceptible to a much worse pandemic. And unless we address those, anything else is just going to be basic patchwork.
If I can add to Dr. Spencer's points, which I just resonate with me so deeply. I remember having so many moments where I wanted to pull my hair out during the Ebola time periods, and I'm trying not to recreate during this time, is that we became so myopically focused on Ebola, and the federal funding, most of it congressionally authorized federal funding, was dedicated on how we would always be prepared for Ebola. And even to this date, states still have Ebola funding that is being leveraged. And what we had a success in being able to get one of the successes of the CDC was being able to advocate for a preparedness fund that could be quickly leveraged to be able to respond, because we got caught flat-footed again with Zika. The biggest failure of this country is its inability to recognize that we will always have emerging infectious diseases. And our global health security is rooted in our ability to quickly respond to emerging infectious diseases. However, people tend to be very focused on how are we going to respond to Ebola? How are we going to respond to Zika? How are we going to respond to coronavirus the next time coronavirus comes around? As opposed to recognizing that the foundational infrastructure we need is for the emerging infectious diseases, which will always be around. This is it. I mean, we live in a global society. Our global health security is critically important for us. So one of the things that we have been focused on, taking Dr. Spencer's advice and guidance, is this notion of, as all of these investments are being made now, right? What are the things that we weren't prepared for? The volume of data that came in, case investigations, disease investigations, and contact tracing are core functions of public health. We manage all of our data electronically. My colleagues in some states still receive faxes. Like they get this information via a fax machine. Even though I manage this data electronically, I was still overwhelmed by the volume of the data and had to make significant investments in the infrastructure that could manage this volume of data. But the money I'm getting to support that work, how do I build a permanent infrastructure that the next emerging infectious disease, whether big or small, can utilize that data infrastructure? And what other core public health functions can now leverage this new infrastructure that we have built just for COVID? So much of what we do in public health and even in healthcare, we have Ebola centers, designated Ebola centers in hospitals, right? But what else could those dedicated Ebola centers be used for? And we pay for those. They're set aside just for Ebola. So when we had to go in and figure out surge capacity for COVID, it was sort of like, you can't touch this sacrosanct Ebola space because it's paid for just for Ebola patients. So we really have to think about how to leverage our resources to be prepared for the next emerging infectious disease in order to be really confident in our global health security in the US.
So, and just to add to that, one question from one of our attendees really has been, as a physician, what would have been your advice to politicians at the beginning of the pandemic?
I think Dr. Schwarz was.
My advice, I would have no advice. I have some advice to physicians at the end, because I want to talk physicians into getting into public policy. In fact, I'll take 2 minutes right now and do it, and then pass the ball. Look, there are now more physicians, medical professionals, dentists and nurses and others. There's a pharmacist in the U.S. House than really ever. When I was in the U.S. House, there were 3 physicians, maybe 4 there. And one of the things that is incumbent upon us as physicians is to get our fellow physicians, women and men, interested in public policy. Where do you start? How do I do that? I'm not going to run for Congress. Well, you start at the local level. You start at the local level. You start in your hometown. And you run for city commission. You run for county board. You run for township board, whatever you have, whatever the local unit of government is in your community. And you move on from there should you choose to do so. But one of the things that physicians have done over the years, over decades, in virtually all cases, is avoid becoming active in the public forum. And that has to stop. We have got to be more active. And that's the way to do it. And I'm proud now to say that there are now in the teens numbers of medical professionals in the Congress. And there are now a few more in the Michigan legislature. When I was in the Michigan legislature for 12 of the 16 years I served in the Michigan Senate, I was the only physician in the entire legislature. And then finally, the last 4 years, Tom George from Kalamazoo came in, and so there were 2 of us. But physicians can't just stand on the sidelines. You know, all of the things that to which you've alluded today, Dr. Nesbitt, Dr. Spencer, are things that physicians need to be aware of, or at least make the case when you come to them and say, you've got to make the case for this. And the best way to do it is to have somebody there in the Congress, in the legislature, that speaks the language. And if you do that, we'll be in a lot better shape. So the message that I would like to leave today from this meeting is this: physicians, my fellow physicians, get interested in public policy formulation, get interested in representing your district, your location, your city in a public body. And for God's sake, don't be afraid to run for office. It's not a lot of fun a lot of times, and you get a lot of brickbats thrown at you. Nevertheless, don't be afraid to run for public office. It's good, it's helpful, and we need to do it. End of sermon.
Thank you, Dr. Schwarz. And to follow up to that question, to that, paragraph there, why do you think more physicians aren't out there running for office?
It's pretty ugly. It's much more ugly than it used to be. Even when I started, that's too many years ago to tell you, but it wasn't that ugly then. It's pretty ugly.
Yeah.
And it's not only ugly for the candidate, it's not a lot pleasant. It's not pleasant for the candidates' families either. At the higher level you go, if you go to the state level or the federal level, it can be pretty ugly. And people say, the heck with it. Why do I want to do that? That's the first thing. The second thing is the money. And the money is totally out of control. And why do you want to raise, say, $2 million to run for a seat in the U.S. House? Who's going to give you that money? Be careful of who gives you that money. I mean, there are all kinds of cautionary things out there in running for office. So there are lots of pushbacks and not a lot of encouraging things to get people to run. And all I can say is that I've survived. There are a lot of people who have survived it that I think did okay and got out at the right time and encourage other people to do it. But we need more physicians to run for public office. Absolutely and positively. And if we don't do that, we have no one to blame but ourselves when some of our causes, some of the causes that Dr. Nesbitt's spoken about, Dr. Spencer has spoken about, get hammered or ignored in a legislative body. It's because there's nobody there to advocate for them. We need to advocate for ourselves and the things that we hold dear.
Dr. Spencer, I can see you nodding there.
Yeah, I am. Although I don't have any plans for political office, for all the same reasons that Dr. Schwarz has pointed out. No, I mean, it has been interesting over the past year because I have engaged with a lot of local politicians here, my city councilman and the chair of the health commission here, with people on President Biden's COVID transition team, having those political discussions, which, in a sense, I feel where I can be a lot more honest and a lot more scathing in my assessment because I'm not a politician and I'm not trying to go for political office. But I do feel that, yes, we need people that have an understanding of what we need to do to be protected, not just for pandemic preparedness, but for getting healthcare really on the right footing here in this country. We need people in the right place, making those decisions and helping guide that discussion. And without physicians, without healthcare providers actually doing that, it's silly to expect that that's actually going to happen. So I'm in complete support, Dr. Schwarz. I'll consider it, but no promises.
Please do.
Thanks.
Ina, there was a question that was on the comment board about, an Oregon physician, Dr. LaQuandra, had his medical license revoked because there was a video showing him or saying that, COVID was like, he was comparing COVID to the common cold. And then, do you agree that I guess, would the panel agree that medical license should be revoked for that kind of conduct?
So JAMA actually wrote an article. There was an article in JAMA, is probably the way I should say it, a week or two ago about how the physician responsibility and what other physicians should do when physicians behave badly, I think was actually the language around it, or compromise the health and safety of the public. And the way it was outlined, it really drew on, it used Scott Atlas, actually, was the sentinel figure in their article, and the role that he took as an advisor in the White House during the coronavirus pandemic as a coronavirus task force member, and citing some of the differences in scientific opinion that he had with other medical advisors and members of the task force, and who and what entity would be responsible for sanctioning. Now, I will tell you, our Board of Medicine did have an increase in the number of complaints that it received about public figures who were practicing medicine without a license. I'll leave it to your imagination who those public figures were. And has also received more inquiries in terms of how to report health professionals who make statements such that masks are not effective on the news media, or who make statements about COVID not being a real thing or it being a hoax, and how those should be handled if those complaints should come to the board. Our Board of Medicine's position is that those complaints should be submitted to the board for review, and they will review them in terms of how their egregiousness, right? So if they are making an assessment of scientific literature and suggesting that their interpretation of the CDC's MMWR around double masking is that it did not actually recommend double masking, they would be correct. So they should not be sanctioned for that. But if they are still at this point making a statement that masks is not a form of source control or reduced transmission, there could be an opportunity to give a written letter of concern. So there are different things depending on what other things have happened in that physicians or professionals past, but they have not adopted a broad policy that one action, whatever that action may be, should result in an individual summary suspension of their license. So they do the same detailed review, investigation, interview opportunity for the physician, et cetera, to make a decision about their license. And all of our boards have taken the same approach. We've seen Facebook posts by nurses, et cetera. And even in our, I will tell you, the vaccine uptake amongst health professionals in the District of Columbia suggests that the healthcare community has concern or vaccine hesitancy that is not dissimilar from the general public. So I don't think that we should be dismissive of the viewpoints and perspectives that the physician or medical community holds, as well as the broader licensed health professional community.
Dr. Fulb, you're on mute.
I usually have to do a shot whenever we're down to 3 minutes now, 2.5, because I was on mute. Really quickly then, you all pivoted, in your career, whether it's advocating on a governmental, level, working through departments, or, going globally. Was there a moment, really quickly, was there a moment each of you had that pivoted you? Could you talk about maybe getting involved? What was that moment for each of you?
I spent 5 years in Southeast Asia, 2 tours in Vietnam, tour in Indonesia, tour in Laos. Got interested in policy, what we were doing, what the country was doing. Thought I would like to get interested when I got back. I did. I went back to my hometown purposefully, and I have never regretted it. Get involved, get involved, get involved.
Dr. Spencer.
Sure. Things changed for me. I went to Wayne State, and I started in 2003 at the medical school with the goal of being a cardiothoracic surgeon, because that is what I found years before made the most money. And after a trip to the Dominican Republic and some other work with Dr. Stanton, who's now over here at Hackensack as the dean, working on global health issues, I completely changed my career path. And for, I guess, the first 10 years out of medical school and out of residency, I ended up spending half of the year working abroad, largely for free. So I failed in my my plan to make a bunch of money, but I certainly feel a lot more successful in my commitment to trying to help out and raise issues of global health equity and other humanitarian issues around the world. So it all started at Wayne State.
Yeah, I would say that during my time at Wayne State, there was an evidence-based medicine course taught by Dr. Smitherman, and I became interested in epidemiology during that time. I think it was because we got to do math and it was a good break from the rest of the stuff. But then by the time I was in residency, I became so very much interested in the systems that influence healthcare access and healthcare policy. And when I pursued my M.P.H, it was more in the healthcare management and policy space. The career pivot happened, however, when I went back to academia after finishing a policy fellowship and decided that I wanted a faster pace than health services research would offer. And I ended up going into governmental public health and have been in executive leadership in this space now for about 10 years of being able to influence systems and policy from the executive branch side. So still having a good time doing work this way. The pace, asking for a fast pace, I think I got more than I bargained for over the past 12, 13 months, but I'm still feeling that I'm able to have an impact in a meaningful way.
Thank you. So we're out of time, so I want to thank our esteemed panelists. Thank you for being such amazing ambassadors for us too. We'll jump on your capes. Ina, thank you so much for helping us. And I just want to mention to all of you that to the people that are out there, the participants, we love to hear about you. We love to hear about your successes and what you're doing. Let us know. We'll send out, information on how you can connect with us. We invite you to become part of the Alumni Association. You can get involved in so many ways. The Alumni Association still directly helps all of these students in so many ways. Besides, underrepresented people, it's not just color, it's also their financial background. And so Wayne State is doing a great job, I think, trying to help, in both of those ways. They're really involved with diversity. They're involved with helping students, pay for not just school, but also meals. And the Alumni Association does an amazing job reaching out and letting the student body know that we're there for them. You can also get involved with admissions. You can get involved with reunion, show up for reunion, speak at reunion. There's so many different ways that you can get involved. So again, thank you so much. We look forward to doing this again. And thank you for being part of our inaugural event. Ina?
Thank you so much. I just want to thank obviously all the panelists today and certainly all of our guests, and very much appreciate your time to be able to spend with us today.
And we'll let you know when the next
Thank you for having us.
Alumni Voices happens.
Thank you.
Thank you.
Thank you.